And then we have the vast majority of people, which account for more than 50% of the world population, with comorbidities. These are people that are overweight or obese, have heart disease, cancer, high blood pressure, cerebrovascular disease or strokes, diabetes, who already have an inflammatory system that's hyperactive because of these disease states they have. So their systems are not well regulated to control and hold back. And so they too have an overreactive immune system. Now, one of the terms that you used was cytokine storm or cytokine release syndrome. And inflammothrombotic response is different than that, although it would appear to be the same. And here's the distinction. Cytokine release storm is the name that was given to the problem that occurs when pharmaceutical drugs are used to attack the immune system in people with cancers, and the body reacts like it should. So they came up with a nice name for it to explain, well, we have a problem from our drugs that we're using for you to treat. What the inflammothrombotic response is not a normal response. It is an overactive response that appears to happen in these people that do not have well-regulated immune system, either because of these diseases or they're immune naive. And that is critical, not only when we talk about the treatment, which we'll get into, but when we talk about vaccines. Because what most people are not well aware of, and let me just state here, I am not an anti-vax physician. I'm an allopath trained at the University of Iowa, which is one of the major research medical schools in the United States. It is the only university hospital that does not allow a private practice physician to treat patients inside its doors. Only academics are allowed there. We don't allow private practice doctors in, and we're very big on research. And we were taught, if you can't prove it, don't tell people. If there's a question, go find it, go find the answer to it, but be methodical about it, be scientific about it, because there's a science behind why this is happening. So I lost my train of thought, which is my typical professor stuff. Okay, so I'm not an anti-vaxxer, but I'm anti-stupid. Okay, and by that I mean you have to ask a question why you're doing something. You have to ask, if you're getting a test, why are you getting the test? What are you going to do with the information you obtain from that test? Does it make a treatment decision that's critical, or does it not? And that's what FMTVDM does for patients with SARS-CoV-2, which again, we'll get into that later. But when you talk about vaccines, you have to ask the question, why would you give somebody a vaccine? What is the function of a vaccine? Well, a vaccine, independent of how it's made, is designed to expose the person to the infectious agent before they naturally get it. Now, why do we want to do that? Well, we want to do that under the premise that if we somehow control this infectious agent, be it SARS-CoV-2 or anything else, the idea being that we can introduce a weakened or not as virulent form of it to allow the body to have a chance to make antibodies, or more importantly, if you've been listening to the discussions over the last 4 to 6 months, T cells, which are the earlier part of the response to an infection. So you have the early acute T cell cytotoxic response, and you have which occurs at 4 to 5 days roughly, and you have the later delayed humoral antibody response, which tends to occur somewhere between 7 and 12 days, depending upon the person. Now, it is that very response that is supposed to be helpful, so that when you then get exposed to, in this case, the virus, naturally, that your body will already be ready to address it. Here's the problem. The vaccine, to do that, is producing the same reaction inside the human's body that the virus does. And it's that reaction that's killing the people. So if they're dying from an inflammatory thrombotic response, which they are, if you give a vaccine to people that produces that inflammatory thrombotic response, you are running a very severe risk of killing people by causing them to have the same deadly reaction to the vaccine that they're getting to the virus naturally.
Wow, that was a mouthful. And so, I mean, because you went, it was a mouthful. You went over a whole bunch of things along the way there. Because I want to go back and spend, because I know this is where you want to put a lot of emphasis on, is on this inflammatory thrombotic response. But I just want to, I mean, my position on vaccines, and I've spent, 40,000 hours and 20 years of my life investigating this. So it's not, it's a studied opinion. I tell people I didn't roll over in bed one morning and have a book fall on my head, and that's what changed my mind. I've spent a lot of time on this. And I like the way that you prefaced everything you said of ostensibly and theoretically, this is how vaccines are supposed to work, because that's not how they work. And it's really not what they do. And we end up injecting foreign matter into the body. If we just had a way to have some sort of an attenuated virus that was really the same virus or particle of bacteria as the one that's out there in the environment, and we just mixed it in with some sterile water, and we could inject that, then maybe theoretically, of the way we've been taught in medical school on how vaccines are supposed to work, maybe they'd work that way. But because of the way that they're weakened, attenuated, gone through, 40, 50, 70 rounds of animal tissues, they're coupled up with a litany of toxic chemicals. And we bypass the primary immune support of our bodies, our skin, our mucous membranes. It gets into our bloodstream through injected directly into a muscle and then absorbed into the body, which isn't anyway how we're exposed. So everything about the, piece by piece of theoretically how vaccines are supposed to work, they don't work that way. They're also inside of the vaccine industry, is they make the assumption that everyone will be exposed to whatever pathogen du jour is that we're talking about inside of any one of the inside of the 17 vaccines that are approved now. Everyone will be exposed. When you're exposed, you definitely will get sick. And not only will you get sick, you're going to get worst case scenario sick. And then, of course, unless you're vaccinated. And so all four of those premises are incorrect. And the fact that nobody is usually exposed to, 5 or 6 or 9 of these pathogens at the same time that we inject into these little baby children. And I know that isn't really the point of our discussion of where we're going with this today, but I do think it's important to know that what Dr. Fleming just laid forward about that is how we're taught in medical school of how these things are supposed to react. But when you couple in that, I had an immunologist, this was years ago. She was an MD who was doing a PhD, doing her residency in immunology. And so I said, well, this is great. I get to talk to this person about vaccines. And she's spending 2 months in my office. She said, I never understood why they think this works. I mean, if the idea is it's supposed to be a match or as close of a match to what's circulating out in the environment, it's not even close. And so you can create an antibody to this thing that gets injected, but does that antibody actually really do anything to the things out in the environment? And the answer, in my opinion, is no, because the data shows from flu shots, from all the mumps, from measles, from pertussis, people can get multiple vaccines, have high, even tetanus, have high antibody levels and contract the infection anyways. So that antibody isn't to what's out there in the environment.
Yeah. So you make several important points there. And the reason why I get very specific about the way that I laid that out is because